Hello, I'm Dr. Alan Malik, and welcome to this third webinar in our series on how to boost your integrated behavioral health program performance. We've been kind of following CJ Peek's three world view here, and so in the first webinar we got into that whole clinical side of things and how much you can make that work better for you. Then we got into in webinar number 2 the whole operational side of this thing and basically all the advantages of automation, what that can do for you as well. And so in this third webinar, we're going to get into the financial side of this, and we're going to start out by actually using CJ Peek's three-world view as kind of the basis of your justification in terms of making the business case. And so we'll get into the different parts of that and talk through the different pieces that go on there. And we're going to get into that automation process. What did that really do for you in terms of recouping those provider intake costs? And then we'll show how obviously automation is going to reduce your operational costs. And then if you start thinking about, you can actually even code better in terms of reimbursement. You can actually meet some of your value-based metrics a little bit better. So it all supports the reimbursement, so you can up those sorts of dollars. And it's actually really easy in this particular environment to show a positive ROI. And most every case that we ever worked with is, you end up with essentially making your integrated behavioral into a profit center, which is, that's the whole, the only way you're really going to make this stuff work inside of an organization. So then we'll go through a little quick case study at the end of this whole thing to look at how it all goes. So here we are in CJ Peek's three-world view, and the problem is that when most people go out there and start thinking about effectiveness and start thinking about programs and projects and so forth, and even models of care and so forth, like your PCBH, you have to think about it from this three-world view, and it really comes down to, what's driving this thing is that it has to have clinical relevance. I mean, you got to be supporting that clinical process. But, in doing so, you also have to be careful that, you can't get in the way of operations. You can't be screwing up those workflows. You can't be doing stuff that IT is not going to let you do. I mean, that whole world is actually makes your organization run, and you have to work with it. And then, from a financial perspective, I mean, you can't be putting in stuff that just can't be cost justified. So you have to come up with concepts and ideas and things that you're working with that meet all three areas. And the nice thing about this is that, you don't have to get into massive detail in terms of how a particular organization runs or works. It's just a very simple model, just three worldviews here: clinical, operational, and financial. So we're going to use that moving forward here. So from a clinical view, if we start talking about doing like in-depth assessment, essentially moving over to a patient interview where you're getting that breadth across, it all comes for free because you basically have essentially recruited your patients as your data entry people. So there's no more cost associated with that. They're just doing the work for you. It's just, you're crunching more numbers, but computers don't really care about that. So, it's that breadth. I mean, and so you can get to all sorts of new information, better information, and you can actually make the whole thing responsive to the patient because you're going to ask for too much stuff. I mean, there's too many things that you can actually go for. Literally every single visit that a patient comes into a medical setting, there's all sorts of things that you can be asking them that's going to help your system. So, being able to lock those things down, be able to do logic inside of those assessments to figure out how do we get to the information we need in the least amount of questions, and making that whole thing responsive to the patient. So, you're dealing with the medical conditions that they have, you're responding to what they tell you, and then you're digging deeper where you need to and so forth. So you need a responsive sort of setup. And then ultimately when you get out of that whole thing, you got to summarize that data up. You got to be pulling up things that are actionable. I mean, a lot of this stuff, some things support the bio side of this whole thing, which is what the medical people are doing. But an awful lot of this stuff, this is stuff that they're detecting. They're detecting social determinants of health. They're detecting behavioral sort of issues. They're detecting psychological sort of issues. And so what they really want to have is summarized data that says, here's what's going on. they can validate it, and then they can figure out what to do about it. They can do the referral, whatever, or they can try to treat it themselves or deal with it with the patient. But it's got to be actionable information. You can't just come up with a generic, your PHQ-9 score was above 9, greater than 9. So we threw the flag on you, but basically it's equivalent. We took your temperature, and your temperature's elevated. You got nothing else to work with. So now you got to go dig in and figure out what's that all about. Where if you do that in-depth assessment, all right, now you got actionable results. Now you cut the labor out for everybody having to follow up on that information that is not adequate for the situation and so forth. And so, obviously from the clinical side, it has to work through the EMR. It all has to be easily accessible in the EMR, and you want to manage things from the EMR. You can't go looking to other systems for information. It just doesn't work. And then, to a smaller extent, but this ability to do the patient management, to be able to go through and run that registry, or to be able to go and do those outcomes on an individual patient and see the histories and pull the information together in a meaningful way. Any sort of support that you can do along those lines all help from the clinical perspective. So then from an operational view, this is all about the automation. This is, how do you maintain your workflows? How do you meet all the IT constraints? So it's primarily the HIPAA constraints and the security constraints. And that all comes through innovative automation that you're putting into the system. But the reality is it's all very doable, and the biggest problem here is not really how to get the IT interfaces work into your EMR. It's actually about where do you put the data inside the EMR, which comes back to a clinical side. And so if you've already fought those battles, you're most of the way to getting your EMR integration done anyway. And then obviously you want to minimize staff involvement. So, the more you can automate your process, the better off you are. And then, if you minimize involvement, then you minimize your training. But you can't have a system that's difficult to use. You want something that's dirt intuitive, punch a number on a launch list and away you go. You don't want to be having people have to think. You don't want to have them to be sitting there looking at, oh, you've had this, this, and this, and therefore we need to give you these 3 measures, and it's only on the every 6th month that we want to do this, or every 2 years, or whatever the protocol is associated with the measure. And so you want your computations that are available to you to automatically do all that protocol manipulation for you. And then obviously, you want that integrated patient management. Now, most EMRs are getting to the point where they're actually able to handle registries and stuff like that. So maybe not as much of an issue there. But when you start getting involved with community programs and so forth, you're going to start sharing across organizations as well. And so you're going to start to find that maybe you want some other types of connections and so forth, which, automation will do for you. So, now from the financial view, obviously the biggest thing here is, along with that savings of time, which really helps your operational view, it's also cuts your costs like crazy. But you also need to think about, if you convert from paper to electronic, there's actually cost associated with paper. Paper's relative to electronic, paper is actually expensive. So, just that move from going from paper to electronic is basically going to save you money. Then you look back to, okay, well, now if I have greater depth of information, I get better documentation of what's going on. It's much easier to code for better reimbursement. And so now you can up that side of the equation as well. And then, you're going to need to get into, the essentially the value-based metrics that are coming through. So, things like trying to cut your time down, knowing that you've looked for certain things to be able to basically audit and show that you've done certain things and so forth, where if you have an electronic record of what's all the interactions you had with that patient, it all comes for free. So that's another consideration you need to think about this, because eventually your reimbursement is going to be a little bit different. It's going to be on that value-based sort of thing. So you want to have your system set up to be able to meet those value-based metrics and so forth. So your different views. So let's talk a little bit more about how do we recoup that provider intake cost. And what we're really talking about here is this is essentially the amount of time that the doc's going to get into digging into the depth of information that you can get from screenings. that you're not currently doing if you're just doing a simple distress measure. And so where that's going to go ultimately, it really is, AI is eventually going to get here and go, oh, we're going to drive every single question, which we could actually go to a system like that right now because we've got the pieces in place to do that. But you're going to basically, where that's going to impact your world is in that patient interview. I mean, in that patient interview, you're going to pull all this other information. You're going to pull all these things together. So what you really need to start thinking about is when you go to do that screening, it's not just a screening, that's an interview. And you need the breadth of information associated with that. And once you start doing that, then you just saved tons of time on the part of staff and providers. And so that is just a major savings and cost doing all that intake automatically. And that's kind of what we showed out of the with that PHQ-9 and QPD study that we put together. So you want to automate that provider intake, and then even to the point of once you automate it, then you can actually even err on the side of false positives to get better look into that world of essentially false negatives that you create. So that idea of doing a PHQ-2 at even a level of 0, anything above 0 on a PHQ-2 sounds kind of crazy. You trigger over 50% of the time, but if you got a QPD doing the specificity on that whole thing, then you can figure it out, and it still works financially. So obviously you want to reduce these operational costs. So you start getting into, it's all the labor, but apps do work too here. Apps are doing all your calculations. It's error-free. Actually figuring out the protocols and so forth. That's all automation. That's labor that you've saved. And then your big thing is your clients and your patients are doing your data entry. I mean that's you go with Don Berwick, and then that's your patient resources is the way to think about it. And then going electronic, getting rid of the paper, and then doing all this automation so you can move your data. You don't have to do data entry anymore. You don't have to put that stuff in an EMR. You can even be generating most of your note automatically through your screening process. And then the whole idea is potentially going to drive that labor cost to 0. There's a very big upside in this whole process. So, on the other hand, you can also do all these reimbursements. And so in most cases, what we've seen is that just from the reimbursement side of this thing, you can turn any screening program into a profit center. And so you don't even have to go through the cost justification, because nobody likes to talk about a negative profit. In other words, you save money through a cost reduction. But you got to look at both sides of the equation. But if you're pure hard dollars, you can even show through reimbursement. You can easily pay for these programs. So showing some positive ROI. So we go through and just kind of go, all right, just for numbers, we sit back and say, okay, doing an electronic administration over paper administration. So maybe we're saving on the upwards of maybe 50 cents when you start thinking about staff entry and all that information and all the work that they have to do. But let's say you save 50 cents in that process, and then think about, all right, you're not going to do that in-depth sort of 10 minutes sort of work all the time, but probably a significant portion of the time. And so let's say your provider's worth $1 a minute, and it's 10 minutes. So every time you have to do the in-depth thing, maybe that's $10 that you're putting there, but you don't do it every single time. So say you only do it a third of the time. So let's put in $3 as your average. You're saving on in terms of using it an in-depth automated administration. And so, we look at the other side of this thing. All right, if you're doing things electronically, well, there are service fees, but they're typically always less than 50 cents. You can get those down under 25. You do any sort of volume. So, you take the license fees if they're applicable. You can push those in there. But you end up with, okay, now we sit back and say, okay, what if we get reimbursement? I mean, even most of your worst Medicaid reimbursements, you can get $7 per administration. Most of the time you get much more than that. So let's use $7 there. Let's say we net out at $3 on all our other costs. So altogether we end up with, $10 per administration. We're actually bringing into the positive side of the equation. So if you go back and say, okay, well, what about my startup costs, for buying tablets and an EMR interface and getting training out there and so forth, so most people don't even see that in their budgets anymore, but on average, that comes in at like $7,500 or whatever to actually do the integration. So you end up with, at $10 within 750 administrations, you've already paid for the system. You're into a positive return on investment. I mean, these systems can pay for themselves, immediately. I mean, like I said, most places use these as profit centers. So this business case is really strong for using this stuff. So, one of the ones we really like is one of the clients that we've been with for a long time, and it turns out they're actually a pediatric location. And it's just a single office. It started out as a single office. They had approximately 7,000 administrations per year. When they started with using tablet launches, basically the first workflow, and they had hard copy reports. And they were back in the old days, the old tablets before we even had iPads and Androids and so forth. They were using the original, we call them bricks now, but the tablets that we built back in the day. And so then they expanded out to using a front desk launch, which, took a lot of the labor off of doing all those launches on the tablets and got some of the error out of the process and so forth, much easier to manage. And then they went to PDF reports and were importing those into their EMR. And then we get into, they put in a small satellite office and they did the same implementation there, so it was real easy to propagate the process across. And then they kind of got hooked up with Community Mental Health Center, and they put together a program where the Community Mental Health Center essentially put a behavioral therapist down at the main site and gave them 3 years to become profitable. So the pediatric clinic ended up, they were already profitable from the screening revenue itself. And then they turned around and now they had this great resource that they could do warm handoffs to. And that behavioral health therapist didn't even take 3 years. I mean, they were profitable within a year and a half. And so they got the whole thing back, and now both sides are having a profit center. So it's a great partnership that they put together between the Community Mental Health Center and an individual medical practice. But the whole point here is that there are great economies in this whole process, and a great deal of benefit from using automation and electronic processing, so that once you get into the whole thing, do the full EMR integration, soup to nuts, it's some of the process improvement and that you're going to really need to make your integrated health programs work better. So, what we've been able to show from all that is that it's real easy to make the business case. And I don't know if you want to scroll down below and leave some comments as to how you think about that whole process and see if it's any different. But that's what we've been seeing out there, and it really works well for people. So, the last thing we want to get into then, we basically said, here's a new way to think about how you do screening, and here's all these great advantages of it and all that fun stuff. But, some real practical hurdles, like how do you actually do it? And so that was kind of what we did about that screening, simplifying that screening process. And then you kind of run across that hurdle of, okay, well, how do we make the business case here and get management to approve and go ahead and implement this thing? And so we kind of went through that in this webinar. And so then your last one is just kind of like, okay, well, it's all great and fine, for everybody else, but, what's it really going to look like for me? And so in this last webinar, we're going to get into what does that screening look like in your clinic if you were to try to do some of these processes and so forth. So scroll down below, like I say, leave a comment if you would. You'll also see the links down there for the fourth webinar, and hopefully we'll see you there. And thank you very much for your time.